All right, I believe we are live. Welcome everyone to the Vision Hudson Valley 2021 Quality Communities Conference. This is the Destigmatizing Mental Health panel, and I am joined today by four esteemed women in the Hudson Valley mental health community. And I am going to quickly do a brief bio. So I'm going to start with Robin Stegman Sackler, who works for Crystal Run Healthcare. She's been a licensed clinical social worker in Orange County for 35 years and a proud member of the Crystal Run Healthcare Department of Psychiatry since 2014. She works with a diverse population of adults in working with them to overcome the effects of grief, trauma, depression, anxiety, and more recently, the effects of the pandemic, which has been particularly challenging and rewarding. She utilizes an integrative approach combining empathy and support with techniques from evidence-based treatments, CBT, DBT, and mindfulness practices. Welcome, Robin. Thank you for joining us today.
Thank you. Thank you so much. Glad to be here.
Happy to have you. Next, I will introduce Wendy Keller. She is a graduate of Columbia University. She's been a licensed practitioner since 1997. She has over 29 years of leadership experience in the mental health and chemical dependency settings. She's the founder of Behavioral Health Services of the Hudson Valley, a private group psychotherapy practice, and she owns and operates Psych ProBill, a behavioral health management and consultation service. Both organizations are located in Newburgh, New York. Thank you, Wendy.
Thanks for having me.
Next, we have Christy Driscoll-Larkin. Christy Driscoll-Larkin is a duly licensed clinical social worker and registered professional nurse with extensive experience in treating individuals with a range of psychiatric and medical issues. Christy currently works in private practice at Behavioral Health Services of the Hudson Valley and is a clinical adjunct professor for Fordham University's Graduate School of Education. In addition, for the past year and a half, in response to the pandemic, Christy has marshaled the development of interventions and treatment provisions for healthcare providers as part of a collaborative initiatives with Montefiore St. Luke's Cornwall. Her on-site work has included primary, secondary, and tertiary prevention of acute stress reactions and PTSD. Thank you for joining us, Christy.
Happy to be here, thanks.
And lastly, we have Darcy Miller. She is a licensed clinical social worker. She's also the commissioner of the Orange County Department of Social Services and the Orange County Department of Mental Health. She's appointed to that position October 2016. Prior to that, she served as the commissioner of the Department of Mental Health for 3 years, deputy commissioner for 7 years, and has been part of the county mental health team for more than a decade. As commissioner, she oversees Orange County's planning, development, and coordination of services of a wide range of social welfare programs under the vision of human services, economic independence, mental health, developmental disabilities, and chemical dependency. Nearly 10,000 residents with mental illness, developmental disability, or substance abuse problems are served by the Department of Mental Health each day. This department coordinates programs with numerous private and nonprofit partners in the county. Commissioner Miller is passionate about infusing the system of care with trauma-informed, culturally competent, and recovery-oriented values, practices, and administration. Darcy, thank you for joining us. That is the most I'm going to talk during this panel because we want to hear from these women. So Darcy, let's just jump in with you. Tell us more about dealing with mental health during a pandemic from the 50,000-foot level of the county.
Well, good morning, Michael, and good morning, ladies. It's a pleasure to be on this panel with all of you. You make me want to go back to my roots of clinical work when I hear on DBT and CBT. It's just such inspiring work that you all do. The state of the county, right? Oh, my goodness. So first of all, I want to say, County Executive Newhouse has been excellent throughout this pandemic. He's been supportive to our community, supportive to his departments, and he's been an advocate for people who need to reach out, who may be struggling with mental health and or substance use issues. So his daily updates to the community have included things like Call 311, which is our 24/7 crisis call line. He's talked about anxiety and depression and isolation and the impact that it has had on people as they've gone through this pandemic. And I've appreciated his advocacy. Those positions of power and election, destigmatizing, which is our topic today, mental illness is what helps us get to the other side, right? It's what helps people have the courage to step forward and say, I think I might need a little help. And there's been nothing more leveling than this pandemic, where people are isolated in their homes, where they're not able to go out and, distract themselves with dinner or shopping or getting their hair done or, all the things that we do to keep ourselves busy. We've only had ourselves and those who are closest to us to be with through some of this time. So what has happened across Orange County and across our country is we've had an increase of people who've needed mental health services. We've had an increase in people who are struggling or relapsing with substance use. And that challenge is something we're all together working hard to meet. We're trying to be where people are at. I will say that virtual, I never thought that virtual therapy, I'm an old-fashioned clinician, in 95, I graduated with my degree and started doing therapy. And I said, there's no way a computer screen is ever going to compare to a face-to-face. And I still think face-to-face has great value, but people have done wonderfully with virtual. We operate 2 clinics, and we have produced more services in the past year than ever before. People have joined in. They've had a need, and they've let it be met non-traditionally on the phone, using computers. I'm sure that all the ladies on this call can say, wow, I'm surprised at how well we've done. At the same time, there are those people who struggle even greater, and they need to be connected face-to-face, and we've opened options for that, and people are returning back to offices. We're able to see people's smiling faces when we're on the computer. When we're in front of them and we're wearing masks, we miss some of that expression. The nonverbals are so important when you're trying to relate to somebody who's struggling emotionally and mentally. So I think it's important. I will say that we're struggling to meet the need of our community. There's more need than we have service. And we need to continue to expand access. The greatest predictor of recovery of mental illness is early identification, appropriate treatment for the appropriate length of time, and you're likely to have symptom resolve. And so we need to ensure that we're...
Darcy, touching on that, early access to services, I think is a perfect way to kind of going to my next question. In real time, Christy and Wendy were over at Montefiore St. Luke's, and they were providing care to frontline employees at the hospital in the height of the pandemic. Can you guys talk more about your experience over there?
Sure. Thank you. And hello to everybody, and thank you for having us. It was a very interesting time, I have to say. No one has ever lived through anything like this. And so, it really actually started with Christy and I having a conversation about what they must be enduring on the front lines. And it was before, you really saw what was public. We said that, that the fallout from a traumatic perspective and what they would be exposed to. And we really didn't know, but we had an idea. We all have training in, critical incidents, in, mental health disasters, but, nothing really of this exact nature. And the hospital, I have to give them credit. Dan Morgan was so welcoming to, the innovative idea of having us come in and assess in real time what's happening. And Christy and I, really spent a lot of time carefully thinking about how to educate people about the mental health fallout from this kind of experience. And, primarily we were working with acute stress, with just the shock, the overwhelming stressful nature of experiencing that much loss, of being on the front lines and exposed and at risk yourself. And, as we all know, at the same time, all of our, as Darcy spoke to, all of our resources and our supports and the things that would normally help us cope with that kind of stress or traumatic experience, those were all gone. We all had to shut down in our homes, no sports, no arts, no outlets really, no religious gatherings. So We really went in there with just education. This is what, acute stress is. This is what post-traumatic stress is. These are some things that we can do to deal with that so that later on, when you're not in mechanical mode and you're not in the crises anymore, which is what we're seeing now, what depression looks like, what anxiety looks like, and there isn't anybody, to normalize this for anybody who might be watching, there isn't anybody in any capacity who has lived through this pandemic and has not experienced a degree of depression or anxiety or loss or trauma. And, how we manage those things determines how sick we may or may not get from a mental health perspective. So we spent a lot of time, trying to discover what they were experiencing and then helping them to identify what healthy things they need to do to prevent themselves from really getting sick or having longer term effects, if that was possible. It was very well received. It was some of the best work that I think either one of us have ever done. And it did begin to prepare us for what you spoke to, Darcy, which was that, it's afterwards. Like, we all go into mechanical mode. We're all creative about, screen time and adjusting on the fly. But, now we're 14 months into loss and uncertainty and discomfort, and we're tired of it. And so people are getting irritated, and then you have to layer that with some of the political unrest and the social unrest that was characteristic of the height of the pandemic as well. And so we're tired. And so there are so many people seeking care for depression, for anxiety, for post-traumatic stress, and for loss. And this is what we spent our time looking at. What's going to happen? What is this wave going to look like? And, how can we help people get ahead of it and, be open to the idea of getting help? And I think in our hospital work, one of the things that's particularly challenging is that those of us who provide care have a very hard time accepting care. Those of us that are in the mental health field obviously normalize mental health as a part of whole health. So that's not the issue. The issue is accepting help of any kind when you are a helper. So I think that, for some of our folks that are in the helping fields, our first responders, our law enforcement, those folks have a harder time, allowing themselves to say, I need help. And so, we've tried to get, ahead of that a little bit in the message as well. It's been a very, very interesting experience. Christy, do you want to speak more to, did I miss something?
No, I don't know. You did a wonderful job kind of capturing what we did and how we did it. I think for me, what was interesting was trying to, like, the coronavirus, the crisis made it clear just how inextricably mental health is from your physical health. You can't talk about PPE without talking about mental health repercussions. You can't talk about patients dying of COVID-19 without talking about grief. You can't talk about unemployment or social isolation without talking about anxiety and depression. So what was nice about going into to talk to hospital staff is that we sometimes have this tendency to separate physical health, mental health, and then this other third rail of substance use disorders. And we can't do that any longer. We really need to look at this whole health model. And I think the coronavirus, if you could say that there was a silver lining in such a devastating experience for it's that. So, the U.S., almost half of all adults will experience mental health during their lifetime. And these are similar to rates of people who suffer from heart disease. So we can't separate them any longer. And I think working with hospital staff is really a profoundly helpful thing for us to be able to talk about. And then somebody was talking about before, I think Michael, you talked about, or Darcy, that we really have a lack of mental health practitioners. And the vast majority of mental health conditions present in this primary care setting. So oftentimes primary care practitioners feel overwhelmed or they're practicing out of their scope when addressing mental health needs. This is directly related to stigma. So there's an immediate referral and outsourcing process that occurs at the primary care setting. So, and because of the shortage and the normative referrals, we have a lot of people that we are losing and not capturing. So there's got to be a greater integration of the general medical and specialty mental health sectors to meet this demand. And we have to improve the training of primary health care to maximize the quality of mental health care services. We have to legitimize and establish clear parity between medical and emotional. So I think the hospital has really made me and my work there think more about that and how we need to do that. And I'm actually kind of curious from Darcy's standpoint on the county level, how, the collaborative care model and where you guys are at with that and what's happening from different agencies as well.
Well, you've all had long careers as I have. And for me to see the changes in how, how we have destigmatized mental illness and substance use disorder in so many ways. I mean, we've come so far, right? I speak about and speak with law enforcement almost every day. So we've seen great improvement there. When we look at the medical model, probably our district programming was most successful in spreading the messaging about how important it is for physical healthcare practice to have either co-located, to do screening, to do referral, to have, we've come a really long way. One of my greatest mentors said, sometimes you have to stop and look back to see how far you've come and then figure out where we need to go forward. So I agree with you. I think that when you look at psychotropics and what is the prediction, 65% or 70% of them are being prescribed by the physical healthcare community. How do we expand training and exposure, and how do we encourage people to come into the field of mental hygiene and have that co-location or that referral ability, just available? I always tell the story about the first time I was asked in my medical health practice about suicidality. And I said to the young person who asked me, I said, what would you have done if I had said, yes, I was suicidal? And she said, I don't know. I said, okay, well, we've come for, that was 10 years ago. So we've come further, right, in the 10 years. So pretty much we hope that always know what to do. If you're going to ask the question, know what to do with it. But we still have work to do, Christy. I agree with you. And Wendy and Christy, so St. Louis Cornwall is so appreciative. There's such leaders in our community, and you were there to support them emotionally through this. And I've heard the stories of how impactful your work was. So all I can say is thank you, as I think they would want to say if they were here to say that.
So I want to get Robin in on the conversation and kind of tie it in.
I was going to piggyback a little bit with what Darcy was saying about the integrated care. And as a provider for Crystal Run Healthcare, of course, we're pretty much on board with that. That's our model here. And the behavioral health and Department of Psychiatry has been, I think, one of the last specialties to join the practice, but we've been up and running, I believe it's about 8-9 years now. And we work collaboratively with the primary care and all the specialists. And we have a nice conversation and flow among all of us so that we can get that overflow. If we can't treat somebody in behavioral health, then maybe we could talk with the primary care doctor and they will prescribe medication for someone who's in therapy. So I think that more practices are looking at that, integrating the model, but it's very, very effective. And we have had a very low no-show rate. We're seeing people, filling our rosters, and people just don't not show because they have telehealth. So we have quick access, and the intimacy that we're able to develop with virtual therapy is incredible. I don't think anybody imagined that it could go so well. And I think perhaps what we're doing is also preventing people from ending up in the ER quite as much because they can have telehealth. And so I think we're doing a fairly good job, but I'd like to see more practices provide the integrated health, and more clinicians, maybe private groups, collaborate with private medical practices.
Mm-hmm.
So,
yeah, I think a very astute point, Robin. And as another large primary care practice in Orange County, one of the first things we did, and I'm sure Crystal Run did the same thing, was look to take care of our staff, open the lines of communications, truly break down the barriers between our employees and our behavioral health department. It was essential, especially in the early days of the pandemic. But we can we agree with everything at Cornerstone that you ladies have spoken about. It truly is about integration of care. I think the issue is access. It'll always be access. There's only so many clinicians available. So what's one way we can, I think Robin talked about, just that, that consult between primary care physician and patient, or between colleagues. But what are some other techniques to create additional access? We've hired a tremendous amount. Our behavioral health staff has grown 4 times over in the past 3 years. We can't hire enough clinicians to serve our community. We're trying to keep up with access, but we can't even hire what is needed for the community. What are some ways? Are there any words of wisdom for our policymakers to kind of increase workforce?
I have some thoughts that don't necessarily involve more clinicians, but just working with what we have right now, because we have had to reach so many people. A couple of different thoughts about that. One of them is, we have a standard of practice here. When we get somebody in here, we contact the primary care provider. And with this level of need and with this volume, what we found was that our integrated model was really just checking boxes, was letting the primary care know, okay, somebody's in therapy or somebody's going to see this psychiatrist. And there wasn't really a quality of collaboration happening that we needed to have when we're managing this volume and to manage these folks well, at least here. So what we did recently was we hired a care manager, a behavioral health care manager that is a designated person to work with the primary care settings that are managing the psychotropic meds. We actually are piloting right now with Cross Valley Health and Medicine. And we had our first few patients yesterday, and it actually went really well, where we're able to share information about evidence-based outcomes, what's working and what's not, and the primary care settings are managing the psychotropics. We only bring in the psychiatrist that we work with on a telehealth basis and on a consulting basis. So similar to the work we've done with Matt, with Matt meaning medically assisted treatment, where we're getting the physicians, primary care physicians comfortable with prescribing medications they don't normally prescribe. It's the same kind of model where the psychiatrist only consults on the medication if there's a really complex situation, but otherwise the medications are managed by the primary care doctor, and our care manager is making sure that there's a quality of collaboration and communication with the primary care provider. We'll see how that works. The other thing that Christy and I have been doing, and we started this in the hospital and it's kind of overflowing into private practice here, is group therapy. I can't speak enough to how valuable that has been in our work with healthcare providers in managing the post-traumatic effects of the pandemic. But, also we just started a stress management group for adolescents. There's a huge waiting list for that. And it's really just about managing stress and understanding how to talk about your feelings, problem solve, understand that you're not alone and that you can, work your way through this and get to the other side. But, group therapy is really powerful in that sense. Additionally, we have started both a family program. We're launching it right now. We're still developing it for folks that have a loved one, a family member, a friend that is suffering with a substance use disorder, because we are seeing a tidal wave of high functioning alcoholism. We were all encouraged to kind of isolate, but also, enjoy a glass of wine. And, for some folks that were, maybe heavy drinkers or hadn't really developed a problem, now they're facing unemployment. Now they're, in their homes all the time. They don't have, other healthy outlets. Some of those folks have developed drinking problems. So we're offering some, intensive outpatient services for that group, but especially for the family members, because with substance use disorders, that kind of a condition, if it develops and in its later stages of progression, really takes out a whole family and everybody that interfaces with, the person who has really become ill. So, Christy has really spearheaded the family and the children component of that, of, speaking to how this affects them. And what do we need to do to support those folks and really disarm the illness, not the person with the illness. So, groups and a different kind of integrated care model is what we're doing.
Let me jump in here. Is the integrated care model, working with your primary care physician as behavioral professional, is that a new phenomenon?
No, it's new in our organization. We would do it, each of our providers, we have 20 providers here. So our providers would, loosely connect, and we had, practices that would allow paperwork to be exchanged. So we were compliant with doing what we were supposed to do, notify the primary care doctor. That's different from having dialogue and really making sure they get a good understanding of the picture, and then that we actually have conversations that are really going to make the difference in the quality of care that they're receiving, and that they're going to see the value, realize the value of a collaborative model where we're working both with the typically, medical aspect of things as well as the mental health. So it's really just an effort it's not new, it's new here. And it's new that we're involving a third party, a care manager, that can bridge the gap between the treating therapist or the treating psychiatrist and the primary care doctor, or primary care setting, I should say.
So let me follow up. It doesn't seem like there's any hesitation on the mental health side. And this is for the group, has there been any hesitation on the primary care side to
You reminded me of the mortality morbidity study that showed that people with mental illness died 25 years sooner than the general population, right? And so that study got people thinking about, wow, how does this happen? And it comes down to whose responsibility is it? And what I hear Wendy saying, and what you've done at Cornerstone, and what you've done, Robin and Crystal, run healthcare, is really said, it's a shared responsibility. Let's get the job done. We can't just treat the medical, and we can't just treat the mental health or the mental hygiene issue. We need to be treating the whole person. Imagine that. And that's how we have longevity, and that's how we have wellness. So I think that there's still resistance. There's probably resistance on both sides, but the physical health community has been allowed to just move forward with more of an exact science than the mystery of mental illness or substance use disorder. And it's kind of uncomfortable. So I think we're moving in the right direction, where we say, this is your responsibility. You can't just treat the physical health condition, the heart disease and the diabetes or the cold. You have to be treating the whole person, and you need partners to do that. You shouldn't have to do that alone. How do we partner? And you guys have given great examples of how you do that.
So I wanted to add something. May I add something? Yeah, I just want to add something. I think that also a lot of times people don't want to say how they feel. They're not comfortable. So the primary care providers, being that first person that they may go to for any health care, I think a lot of them now are doing depression and anxiety screenings. And a lot of people feel more comfortable filling out a form than speaking face to face. So I think that, I find, at least here at Crystal Run, the primary care providers are very helpful in catching the first warning signs. And this year it's been on fire, because they are catching the anxiety that goes along with it and referring people to us, but very willing to treat these individuals. So I think it's really an important entree into the mental health system. But the surveys and the screenings are very helpful for people who just aren't comfortable putting words to their mental health or their feelings. It's too intimidating. And they're afraid, with the stigma of being considered ill. We're trying to overcome that stigma and that taboo. And with the search this year, I think it's really across the board. It's shifted people's perspective from seeing their mental health problems as a very internal and individual problem to more of a community, county, national, and global problem. So it's like we're in the biggest support group ever. Speaking of support groups, we're all in this one together. So even as a therapist, we can use that in our sessions. We're trying to help people understand that they need to protect themselves, but we also don't want them leaning fully into their fears all the time, just by having a conversation, listening. So even for those people who can't have access to services quickly as we'd like, just making it a more comfortable environment everywhere, in our work settings, in our home lives, in our communities. If people are getting back to their faith centers, making the conversation more open and accessible is warming people up to reaching out. It's a good start.
Great. And so that was one of my questions, and I'll ask Christy this: has COVID positive or negatively impacted the destigmatization of mental health services?
Well, I'm sitting here and I'm very excited about all the work that these particular agencies have been doing. But looking back, there was a seminal article written in 1978 about primary care and the de facto mental health system. We have been talking about this for over 40 years. And there has been movement, but there's not enough. And that's the part that I'm trying to focus on, and thinking about this panel and thinking about destigmatization and how we can really do that. And this is something that we don't talk about very much. We have to start acknowledging our own stigma as mental health providers, because if there's a lot of it out there. And I'm a salesperson. I like to ask questions and get results and be able to quantify that. So in my search of looking at stigma in mental health, I came across something that's called Opening Mind Scale for Healthcare Providers. And I hope that as mental health providers, we all go. It's called the OMS-HC-15, and it's a 15-item scale for healthcare providers to look at how they see mental health. And I took it because I was very curious. I feel like I'm very open-minded. I've been doing this for 23 years, and it was a curious score that I got. It wasn't overly high. It wasn't on the, wow, you need some work on your stigma around mental health, but it was interesting. One of the questions asked, if you were in treatment, be willing to talk about that with colleagues. I paused for a second. And then I thought, we need to start having conversations amongst ourselves about how we feel about mental health. When I was in school at NYU, you had to start treatment to continue in the clinical social work program. And from that point, I have been in treatment for 23 years. I've done group, I have done individual, and I would never give that up. It'd be asking a dentist to never have a cleaning or a follow-up cleaning in all the years that he's practicing or she's practicing. So we have to start acknowledging, if we really truly want to start destigmatizing mental health, we have to start asking ourselves what our own views are and how that translates to our work. Because I'm telling you, it does. Because if we're talking about even mental health practitioners, certainly primary care. When I was in nursing school, we had a half a semester on psychiatric care. And everyone in my nursing program couldn't wait to have it done. And we were combined with the medical staff in the School of Dentistry, and people scoffed at mental health because we need to start, like I said, looking at whole health and legitimizing that this is not a separate entity from physical health. And once we do that, we're going to see a change, a real change. And those scales that, Robin, that you were talking about, the HQ9 and the GAD-7, they do start to make it easier for practitioners to have this conversation. And it makes it easier for the patients to say, wow, just these questions alone are bringing up things that I didn't even know that I was thinking about. Going back to our work at the hospital, we've done 2 scales there that we, it's a burnout assessment scale and a PTSD screen. And just having those questions asked of the staff made them more likely to talk about, acknowledge their own mental health needs. So you're right, Robin. Sometimes we don't have the words. And if we can't do that, then it's our duty and our obligation to figure out how to bridge that gap.
I was going to comment also on treating the provider, as you were saying, the self-care that's required. And it's really important for employers to consider making an environment safe and open. And just this morning, as I was driving in, I was listening to NPR, and I think there's a tennis player who did not want to speak publicly because of anxiety, I believe it was. I didn't catch the whole news report. But just like, someone would take a physical health day because they're not feeling well and they call out and take that day, we have to give people permission, whether it's the individuals we're working with or ourselves, to also have a moment to regroup. We have to take care of ourselves. And so I think that taking a look at how we self-stigma is really important, and trying to overcome that barrier. Because we didn't have access, I think, as Darcy was saying earlier, to the things that brought us stress relief. But I know I sure got a new appreciation of music this year, cooking with my music on, and, of nostalgia, those things that keep us safe. We are missing routine. We're missing certainty on the highest order this year, and providing and finding some routine and certainty for ourselves, and disclosing that appropriately with those that we serve. This has been a challenge for everyone. Again, we're all in this one together. Yeah,
Robin,
but we're getting back to a good place. I'm sorry.
We were talking about, and one of the questions that we kind of talked about before, Michael, is having a stigma-free company, and what does that look like, right? Mm-hmm. Our work environment, as we see at the hospital, or ourselves in our practices and our organizations, it has a huge impact on us. It's really imperative that our workplaces start to be mental health supportive. And 52% of employees say that their companies don't do enough to promote that. So there are ways to take steps to change that. And I think we need to really look at our own agencies and organizations, and are we doing that? And that even in the mental health field. So do we have adequate insurance coverage for people with mental health needs? Employee assistance programs. Look, EAP, I think we need to be honest about this. Not many people want to utilize it. They are afraid. We need to look at that, restructure that, rebrand that. The accommodations or disability planning for people with mental health conditions, access to quality care, policies that support family caregivers. There's a lot of them, particularly in the hospital. So supervisors and employees should be talking openly and having conversations about how to support employee mental health, and be proactive with coworkers that may be struggling. We talk about this in the hospital all the time. If you see something that seems unusual for your coworker who you see almost daily, say something, talk about it. We need management training for sure for upper management, not only for their own mental health needs, but for the people underneath them, and what it looks like. What are the signs and symptoms? What can you do? and really start to talk about our language. And not I have bipolar, or I have bipolar disorder, but not I'm bipolar. So there are these little nuances that we all have to start to consider within our workplaces. And I think those are just some of the ways that we can start to look at that and challenge different organizations to really look at what their mental health policies are.
So I think that I would love to ask the question that everyone on this panel has over 20 years of experience, and sometimes a lot more. You've had quite the career already. Your predecessors have, there is a big shift as you folks are in the middle of your career for the newer clinicians that are just coming out. Is there a generational shift in kind of how we treat and destigmatize? And, when we talk about the clinician itself and the conversation is gravitated towards there, are younger clinicians more open to talk about, or, are they leading a charge on destigmatization as opposed to, your predecessors when you guys were just coming out of grad school?
I think the social emotional learning curriculums in schools, right? So we've come away in schools. We have talk about adverse childhood experiences, knowing that trauma exposure can lead to long-term chronic physical health and mental health conditions. I mean, the marketing around that, the messaging around that is new. So clinicians coming up. When I came out of school, there wasn't a lot of talk about trauma. Bessel van der Kolk, when he started talking about the biology of the brain and the impact of trauma, I was like eating that stuff up because I was so excited by what he brought forward. That's now just part of practice. I mean, if you didn't learn that in school, yes. So we've come a long way in understanding the brain, understanding the biology of illness, and the messaging is different. So young people coming out of school may have had conversations, but we're dealing across the lifespan, right? When you look at the aging population specifically, who have a high suicide rate in that population from 55 and older, they're at risk. Many of them just left their primary care practice office and died by suicide. Or within the last month, it's the only practitioner they saw was their primary care practitioner. So I do think that the young people coming out today have a more solid foundation to work with than what we did when we first came out and began this work. And I love what Kristen said about, let's be honest about what our challenges are. My children who taught me the most, when my daughter was diagnosed very young with a serious anxiety condition, I was like, oh my goodness. I have to talk about this. I have to go. I'm the commissioner, and I had to take my daughter into a therapy session. And it taught me my own stigma that I was carrying and helped me to work through that because it's hard. It's hard to acknowledge in a society where you might be judged by your diagnosis. So we do have to acknowledge that and take care of ourselves throughout that. So Mike, I think you bring up a good point of where our new clinicians are coming in with a different foundation.
I think that I agree that the younger clinicians coming into the field now are more adept at talking about their feelings, and they're not as concerned about keeping up with appearances and some of the old language and stigma that prevented people from reaching out for help. So I think we're going to be welcoming in a lot more openness and positive attitudes about mental health care in the coming years. I think we have a lot to look forward to in that respect, the young clinicians.
Wendy?
I would definitely agree with that. It is refreshing to see these new clinicians coming in with a different attitude and acceptance of mental health as a condition that's treatable and widespread. I think that for me, my fear a little bit is that, like with most things and most movements, that we have a vulnerability to overcorrect. Robin, you talked before about discomfort, And I think, one of the things that I use in my practice frequently is that, anxiety, depression, whether they're a diagnosis or can be labeled or should be labeled, as Chrissy spoke to, or not, we all experience those things. And it's important to talk about it, to normalize it, and to be able to address it. But discomfort, uncertainty, that's part of life. And, I think we have to, remind ourselves and these new folks that if you have anxiety, it doesn't mean that you have a lifelong sentence to suffer with anxiety, that you can just be experiencing anxiety as part of, current stressors or maybe past stressors, but it's something that you can work through and overcome. And life is not void of discomfort and uncertainty. In fact, those things are your friend because they challenge you to search inside of yourself and develop skills, problem-solving skills, tolerances, insights that you otherwise would not have to develop. So when people bring their kids in and they're like, oh, my child is suffering from anxiety, and my kids have all, I think, 3 out of 5 have been in therapy. So I too have experiences, but they're anxious, they're uncomfortable. This person in their classroom doesn't like them. And okay, that's a normal part of life, and that is very anxiety provoking, and it's very uncomfortable, but you can work through this discomfort. Let's talk about how. Let's talk about the feelings. Let's talk about problem solving strategies. Let's talk about your self-worth. Those things are normal experiences that we have, and not necessarily something terrible. It doesn't mean there's a problem. It means there's an experience to have. And I think that, I'm trying to help people navigate some of those experiences sometimes rather than get caught up in labeling themselves, diagnosing themselves, or, having the experience that because they're struggling right now, they have a lifetime of mental health challenge to look forward to. That's not true. We all experience, mental health problems at some point in life. It's like saying you get through life without having a common cold. Well, sometimes we just get through a common cold. It's part of, life. You take some vitamins, you drink some fluids, and you get through it. And then sometimes, it levels you. And,
But it doesn't define you. Right. It doesn't define you, the common cold, any more than
down the home stretch there.
Right? Any more than your anxiety defines you. Exactly.
Yes.
A lot of stigma around medication too. And medication, not everybody needs medication, and medication is only 50% of the solution. You may need it for a time. Some people do, depending on the symptomology, and that's where you need experts to be able to do assessment. And it's important to take that and take it when it's been prescribed. But when you don't need it any longer, that's okay too, because the learning, all of the attributes that Wendy talked about that you can develop throughout a therapeutic process can lead to expanded recovery where you don't need medication anymore.
No, I think that's a great point. And I even see it in my family and my social circles. Everyone's more apt to talk about their feelings than they were 10 years ago. Or, it is, I come from a Irish cat, even though I have a Greek last name, I was raised Irish Catholic. I'm not, so it's like no one talks about their feelings growing up. You even see that generational shift, how I raised my children, how me and my wife raised our children, how we talk about trauma. But also my parents, they talk about it now. It is, I think so whether there's pop culture, the things you see on TV, I do think there's been a positive shift in, how therapy is not a dirty word anymore. And that, you hear people, they go to therapy all the time, and it's because they want a third party, because talking to your partner or talking to a parent, you're going to get a biased opinion, and it might not always be. So having that ability to kind of just see someone on your own, my hope is that we all kind of move towards that and continue to move towards that, and it becomes destigmatized further as we move forward. We have 10 minutes left. So for folks that are on here, what are some tips? We'll do like a rapid fire. and we'll go around the horn. What are some tips you can give our listeners today if they're struggling with their mental health or they know someone who's struggling with their mental health? Darcy, we'll start with you.
Well, first of all, Google is incredible. Google can be your friend. You can learn a lot. You have to be careful about what you pull up, but you can learn a lot. So you can do some educating of yourself. And most important, find that person that you trust, that you feel safe with, to have a conversation with. Figure out what you need from that person and really sit down and have the courage to share with them what you're going through. And that will help to open up your next steps. And I'll leave the next step for someone else to speak about.
Robin.
I was going to say what I had mentioned earlier. If you have a hard time saying what you feel, write it down. Text someone. I have patients telling me all the time they text their partner in the other room. Texting, while it may also lack a certain degree of intimacy, if that's the entree to get help, if you can ask someone, a friend, through text for their support, and it's important that we make time for people. And that we encourage people and that we let them know that when they reach out for help, there's often relief behind that. I often like to say, don't let your fear interfere for reaching out and getting help. We have to take the shame out of it. So there's no shame in asking for help. And we have to promote that in our households, in our communities, and in our conversations, wherever we go. And then I think it will help people, reach out more. That would be some of the tips.
Christy.
So I have so much to say on this, but I'll try to be brief.
Yes, you're fine.
Mental health disorders are medical conditions. We have to kind of keep driving that home. They're conditions of the brain. They involve changes to thought, feeling, mood, behaviors. They can cause biological, lifestyle, environmental factors are caused by. So mental illness conditions is not your fault. And more importantly, mental health conditions can be effectively treated. People need to hear that. You need to educate yourself around it. Education is power. It reduces fear. It reduces bias. It reduces stereotypes. Mental health isn't only about being able to identify symptoms and get a name for it, but it's also about dispelling false ideas about mental health conditions. Get treatment. It may feel scary to ask or be identified with a mental health condition, but you can have these collaborative care teams or primary care physician or mental health provider, and they can work with you. I also think it may sound hokey, but be kind to yourself. We don't talk about that very often. They're not a sign of weakness. It's not your fault. You're not broken. Like I said, physical and mental health needs, there's no difference. Understand your language, be very mindful of what you're saying and how you're talking to yourself. Educate other people around you. When you, like I said, knowledge is power. It really dispels judgment and it builds confidence in yourself. Find support for sure. And if you can, speak out against stigma. By helping others and sharing your experiences, it can be extremely empowering. And then in terms of, I'll let Wendy if she wants to talk more about that. And also there's a whole host of things that family members and friends and coworkers can do, but I'll dish it off because I can keep going.
Thank you. It's hard to go last. You guys had so many very, very valuable things to say. I think if I was to add anything, it would be just to say that you're not alone. Nobody that struggles with mental health issues is alone. Discomfort is your friend. Discomfort is where the growth begins. That's where the freedom begins. That's where the health begins, is embracing the discomfort and moving toward it instead of moving away from it or, allowing shame or stigma or any of those things to prevent you from addressing what you're uncomfortable about. And for parents that have kids, talk about yourselves. There isn't any parent that can't look back on their lives and say, wow, that was a rough spot for me. Talk to your kids about what you struggled with and how you got through it. That is the best way for your kids to get the message that they're free to talk about their own struggles. when they see that, what you have done, how have you gotten through this? Obviously in an age appropriate way, but I can't undermine the value of talking about yourselves and your feelings. I do that in my everyday life to my peers, to my colleagues. I talk about my own challenges so that, if they should struggle with something, they know that I too have been through something like that and was willing to talk about it. Those things primarily. And just one more thing I'd like to loop around back to, and that is telehealth versus in person. As Darcy said at the very beginning of this, I think we all have gained access and learned how to adjust and also to value telehealth. I also think that, again, with the overcorrecting ideology, that we can't replace face-to-face intervention with telehealth alone. And so we have to be very careful about where we employ that. It's absolutely great for connecting when you can't otherwise connect, and, for problem solving, symptom management, but it does not replace, face-to-face therapy. Group settings where, safe group settings where, you can really read a person's body language, where, it allows for, they're different, not exclusive. And so I hope that we don't, completely shift to that, to more of a primary telehealth platform. That being said, there are so many resources, as I think Darcy mentioned, the apps for mental health. There are so many tools available for people to just, to learn about symptoms and to learn how to manage themselves and manage their symptoms. Meditation apps, stress management apps. Headspace is one of them. Insight Timer, Calm. There are a ton of mental health and stress management apps available, and especially the younger generations, they are open and fluent more than us sometimes in using them.
Can I ask a quick question? Because I signed up for BetterHelp a while back. I want to get, what are your thoughts on that? Just quickly, because it wasn't anything like I expected it to be. And I've been in therapy before. This was just, it wasn't all that it was cracked up to be. So I think it goes back to your point, Wendy, that you can never fully replace, that in-person visit. Telehealth will get there, but there's, it seems like there is a cultural push to kind of have that on-demand texting back and forth, possibly a phone call. So does anyone have any thoughts on that as we close out? We have 3 minutes left.
I have some thoughts on that, and one of them is that I think that one of the things we need to learn as a society and remind ourselves of is that delayed gratification is an important life skill, and you can't have answers and solutions on demand. Sure. It prevents you from having to work through that discomfort and learn how to tolerate uncertainty, very important parts of life. So no, I think that one of the negative aspects of that is that it reinforces what we've learned from technology, which is that we can Google anything, we can, order it on Amazon and it's right there. And you're not gonna get that outcome with mental health issues, or, especially when there are long-term issues to, really kind of resolve and work through.
I also
you have to do the work.
Gotta do the work.
It's about the work, but essential. The foundation to that work is about connection. You cannot have connection and do this work without seeing someone, talking to someone, hearing them, seeing their body language. We talk about our 5 senses when we ground somebody with trauma. That happens in the room. And it can happen on telehealth, and I'm a huge proponent of that. But we cannot, besides the delayed gratification, and we have to learn to be able to sit with emotions better, we cannot lose connection, because that is where the work really happens.
I cannot say again how important it is in all of the things we talked about to help make the conversation happen. If you struggle with a mental illness, there's a 24/7 hotline. So the Orange County Crisis Call Center managed by Mental Health Association, you can call 311 or 1-800-832-1200. And that helps to connect you to the larger system of care. It's a moment in time. You can also do the text line, which Robin said, if people are not able to communicate verbally, they can use the texting. So very important to know that resource is out there.
Great. We have 1 minute left. I have to get this plug in. The attendance to this event was free. So for all those folks that are out there in the world that are listening, donations are greatly appreciated. And Jacqueline, if you could put that link in the chat box, that would be great. I want to thank the four of you for such a great conversation on destigmatizing mental health. I hope the people out there in the world that were watching this found it to be valuable. Thank you. Have a great day.
Thank you.
Thank you so much. Bye-bye.